بسم الله الرحمن الرحيم. شكرا دكتور هيثم، بشكره على مجهوداته، واتمنى ان شاء الله انه على ايديه هتبقى في انشطه احسن وننهض بانشطه الشعب ان شاء الله. احنا هنتكلم على atrial fibrillation, and we all know that the atrial fibrillation one of the most common arrhythmia, where it has many global prevalence arising due to the increase in the aging world population. Very important to know that atrial fibrillation increases many cardiovascular outcomes, adverse cardiovascular outcomes, but what is important and I want to stress on is the depression. Which is reaches up to 16 to 20% of patients. Even sometimes some patients may tend to have suicidal ideas, and impairment of quality of life increases up to more than 60% of patients. But on the other hand, atrial fibrillation ablation is a well-established treatment for prevention of AF recurrence, and when performed by appropriately trained operators, it could be safe and more superior to antiarrhythmic drugs for maintenance of sinus rhythm. And with all the increased technologies and all the options that are offered by the companies, atrial fibrillation ablation can be a first choice treatment in many patients. In the structured characterization of atrial fibrillation, the recent guidelines in 2020, with the 4S system included the symptom severity, which is very important in characterization of the patient and assessment of the patient, and it is important for us to know whether the patient is symptomatic or not, because a highly symptomatic patient is an indication and could take the way for AF ablation. Also the severity of AF burden, either whether it is paroxysmal pattern of atrial fibrillation or persistent pattern, and the total AF burden is an important factor in assessment of patient and deciding whether to ablate AF or not. And of course the substrate severity, and this is of course related to the comorbidities and the cardiovascular risk factors that the patient has. We all know the guidelines, and we all know that AF ablation is an alternative to antiarrhythmic drug if one antiarrhythmic drug failed to control the symptoms of a patient in patients who are either paroxysmal atrial fibrillation or persistent atrial fibrillation, whether they have major risk factors for AF recurrence or not. What are the major risk factors for AF recurrence? It is the significantly enlarged left atrium, the advanced age, long AF duration, renal dysfunction, and other cardiovascular risk factors. So any patient, even if he has a persistent atrial fibrillation with those major risk factors, they are indicated for AF ablation if medical treatment failed. And this takes class 1 indication with a level of evidence B. Even with the major risk factors for AF recurrence, it is indicated with a level of evidence, class 1 level of evidence B. And at the same time, atrial fibrillation as a first-line therapy is indicated in paroxysmal atrial fibrillation who are highly symptomatic, after considering, of course, the patient's choice and the benefits and risk of the procedure. But it takes class 2B, a lower level of evidence in patients with persistent atrial fibrillation. But it came to take class 1 in patients who have tachycardia-induced cardiomyopathy, so AF catheter ablation is indicated as a first-line therapy with class 1 indication in patients who have tachycardia-induced cardiomyopathy. And it took class 2A indication in selected patients with reduced ejection fraction, and we will talk it in details about patients with heart failure. So it is indicated in patients with heart failure, but the guidelines or the statements at that time did not specify what are the criteria of patients who have heart failure and atrial fibrillation, what are the criteria for ablating atrial fibrillation. And of course, they recommended that we should take in consideration the procedural risk, the major risk factors, and discuss these issues with the patient himself. And this is the algorithm that shows that atrial fibrillation as an alternative for antiarrhythmic drug is indicated for paroxysmal atrial fibrillation, persistent atrial fibrillation, with or without major risk factors. Okay, we should identify, we should know who are the patients who are less likely to benefit from AF ablation, or that they have a less outcome, or not a high benefit from AF ablation. Of course, the persistent and long-standing persistent atrial fibrillation, left atrial dilatation, patients who have extensive atrial scarring or fibrosis, they of course have a less outcome or a poorer outcome. Structural heart disease like hypertrophic cardiomyopathy, there is increase in the atrial wall thickness, which may limit the effectiveness of ablation. And of course, the valvular heart disease, because the hemodynamic forces causes more electrical remodeling and more structural remodeling, so it reduces the success of maintaining sinus rhythm. Some group of patients, they have, yes, they can benefit from ablation, but they have higher risk of procedural complications, like older patients, like patients with heart failure, like patients who have higher risk of ischemic stroke. And there is a question about the genetic susceptibility, if there is a factor or a genetic factor that can impact the success of AF ablation. There are many prediction models that were published that can predict what is the potential benefit or the risk of AF ablation, and what is the probability of success of atrial fibrillation, like the Apple score, like the CAP-AF score, like the Atlas score. All these scores try to predict who are the patients who will benefit more from AF ablation, but all the models did not precisely determine a clear criteria for the patients, with no impact on the guidelines, for example, or no impact on the criteria or statements by the European or by the American Heart Association. Regarding heart failure, the indication for AF ablation in heart failure depended on two famous trials, which are the CASTLE-AF trial and the ATTACK trial. The CASTLE-AF was done in 179 patients for catheter ablation versus conventional treatment in 184 patients. And they found that AF ablation was associated with decrease in the composite endpoint of mortality and morbidity and hospitalization for heart failure. And this was mainly derived by the decrease in the total AF burden on those patients. So they had less AF episodes, which was positively reflected on the heart failure symptoms, so they had less hospitalization rates. Also in the ATTACK trial, which was done in 102 patients for catheter ablation versus 101 for medical treatment in the form of amiodarone, they had improvement in the ejection fraction, they had improvement in the 6-minute walk test, they had improvement in the Minnesota Living in Heart Failure questionnaire, and all these impacts was derived through improvement of the AF burden. So it was a matter of benefit in the morbidity and the mortality, and not regarding the symptoms, but this indication was derived by improvement in the mortality and the composite of cardiovascular death and hospitalization. So we did not have any clues or any strict ideas which heart failure patient can we ablate for AF ablation. But some data from CASTLE-AF trial showed that patients with NIHA class 1 or 2, and patients with non-ischemic etiology, and patients who had early atrial fibrillation can have better outcome. On the other side, enlarged atrium or evidence of atrial myopathy or atrial scarring, if shown by cardiac MRI, and the presence of LV scar if a patient had ischemic myopathy, these were a bit having poorer outcome. Another statement in the guidelines into 2020 stated that weight loss is recommended in obese patients. And this takes us to the very important matter of adjusting modifiable factors, because we have many risk factors that contribute for the formation of abnormal substrate in atrial fibrillation, like hypertension, like diabetes, like physical inactivity like dyslipidemia, like smoking, like alcohol. All these factors contribute for formation of abnormal substrate for AF and results in poorer outcome with rhythm control strategies, either by antiarrhythmic drugs or by catheter ablation. Because all these factors can increase the left atrial fibrosis, increase the structural remodeling, increase the inflammatory markers, causes electrical changes at the cellular level. So it causes structural changes, structural remodeling, and electrical remodeling. And the adjustment of these risk factors are very important, either in increasing, either for decreasing the atrial fibrillation burden in patients medically treated, or even after AFib ablation, the risk factor modification can increase the success of ablation outcome. So it can be beneficial before the ablation and also after ablation. And these are many trials that showed the beneficial interventions that caused better outcome in AF burden, controlling the blood pressure, controlling the weight loss, controlling the alcohol use, obstructive sleep apnea. All these trials showed better AF burden with control of these risk factors. So what are the goals? I want the diabetes to be less than, the hemoglobin A1C to be less than 7, blood pressure not more than 140/90, optimizing the body mass index, treating obstructive sleep apnea with CPAP. And we showed a study here in 2014 that showed that AF ablation catheter, the outcomes were better in patients who were involved in a program specified for risk factor management, with a better AF survival after a single procedure or even multiple procedures. So in conclusion, ablation improves quality of life in patients with symptomatic AF. Proper selection of patients for AF is crucial to increase the success rate, and we need to know who are the patients who have a poorer outcome to increase, to decrease the risk and increase the AF ablation success rates. AF ablation is indicated after failure of drug therapy in paroxysmal and persistent atrial fibrillation, and it is indicated as a first-line therapy in selected patients with paroxysmal atrial fibrillation and also in tachycardia-induced cardiomyopathy. Older patients, longer AF duration, larger left atrial size, and renal dysfunctions are all factors predicting worse outcome for AF ablation, and identifying patients who are less likely to benefit from AF ablation can highlight areas in which future research might lead to better AF outcomes. And adjusting modifiable risk factors are important in deciding which patient we can need for AF ablation, and also it can increase the success rate in patients who already had AF ablation if specified programs were followed. Thank you very much.